pharmacists can have on meaningful use criteria for stroke, and I'll go a bit more into what that is. I'm a clinical assistant professor at Rutgers University, and I'm contracted with Morristown Medical Center in the state of New Jersey in the United States, and I work with the internal medicine team there, the teaching team. Okay. This is my contact information. If anybody has any questions beyond today or would like a copy of my presentation, feel free to reach out to me. So as I said, I'm contracted with Morristown Medical Center, and this is my practice site. We're a 650-bed community teaching hospital, and we have about 35,000 admissions per year with about 84,000 emergency room visits. We are a designated Level 2 trauma center and a verified Level 1 trauma center for traumatic brain injury. And importantly, I want to point out for today's presentation, we're a Joint Commission designated primary stroke center since 2006, and a New Jersey Department of Health comprehensive stroke center since 2007. And I'm sorry, just a little bit more about what I do. So I am contracted with the hospital, and I work on a multidisciplinary team that consists of an attending physician, a senior third-year medical resident, 2 intern residents or first-year residents, myself, a pharmacist, and then I usually have 2 to 3 pharmacy students with me, and then there's also at times medical students on the team. And it is a teaching team, so we do a lot of education. Okay, so meaningful use, in the definition that we're going to use it in, is the minimum U.S. government standard for using electronic health records. And this is for using this information to communicate from provider to provider, from provider to insurers, and from providers to patients. And the goal of meaningful use is to improve the quality, safety, efficiency, and to reduce health disparities amongst patients. We also try to engage patients and their families, members, and caregivers. Also, a goal is to improve the care coordination and population and public health overall. So with meaningful use, there are 3 steps to meaningful use: step 1, step 2, and step 3. We're currently in step 2 in the United States. And what this is Medicare and Medicaid use this electronic health information or electronic health records to develop what they call an incentive program. So there are financial incentives to go along with following the appropriate meaningful use. So a little bit of background. In May of 2014, I initiated this program at Morristown Medical Center with one of my colleagues there, and also in conjunction with the multidisciplinary stroke team. And this program, basically pharmacists they're evaluating patient charts and then initiating appropriate interventions and counseling patients regarding their disease state and their medication management post-acute ischemic stroke. And the pharmacist's role in this program is targeted towards improving several measures of meaningful use, and I'll go over those. So there are 5 measures of meaningful use that the pharmacists are targeting. And they're mainly around drugs, obviously, medications, and medication counseling and education. So we're looking at NQF 0435, which is stroke 2, ischemic stroke. And basically, this measure wants to make sure that patients are discharged from the hospital post-ischemic stroke on antithrombotic therapy. We are also looking at NQF 0436, stroke 3, ischemic stroke. And this measure looks at patients that have had an acute ischemic stroke that also have atrial fibrillation or A-flutter, and to make sure that they are, upon discharge, that they are guaranteed that they are on an anticoagulation therapy as well. Another measure that we look at on discharge is statin medications. So any patient that comes into the hospital post-acute then has a stroke, if they have an LDL greater than or equal to 100, or they do not have any LDL drawn, we don't have a measure, or if they were admitted on any kind of cholesterol-lowering medication, regardless of the type of medication, these patients, unless contraindicated, should also go out on a statin or an HMG-CoA reductase inhibitor. So that's another thing we're looking at. In the hospital, we also want to look at NQF 0438, or stroke 5 ischemic stroke. And this measure looks at that patients are started on antithrombotic therapy by the end of hospital day 2, unless contraindications exist. And the last measure that we tried to make an impact on is NQF 0440, which is called Stroke 8 Ischemic or Hemorrhagic Stroke, stroke education. Just a disclaimer on this, we specifically focused on ischemic stroke patients, so we didn't have such an impact on hemorrhagic stroke patients, but that population is much smaller at our hospital than the ischemic stroke patients. Okay. So our objectives were to see if we can make a change in the measures of meaningful use scores pre- and post-implementation of the pharmacist involvement in those 5 scores that we spoke of. And we also looked at the number of pharmacist documented interventions for each measure during the study period. Okay. So we began again in May 2014, and this is a continued process that we're trying to keep doing and continue forever. Pharmacists review the patient's electronic health records, and we provide intervention recommendations that patients admitted with stroke are started, discharged, and educated on appropriate medications, including, as we spoke, the antithrombotics, the anticoagulants, and the statins. We also provide educational pamphlets to patients, and I'll talk a little bit more about that, and their families or caregivers, which will address activation of emergency medical system, a need for follow-up after discharge from the hospital, also risk factors for stroke, warning signs and symptoms that they are having another stroke. And then we record all of our interventions and education in an electronic database. And I just wanted to mention, so these measures of meaningful use are so important because we know that by starting these medications and by educating the patients, we do reduce the chance of patient coming back with a second stroke. Okay, so patients, we used a system called Care Focus. It's a data mining system, and we use this to identify patients with ischemic stroke. Basically, our criteria were that the patients were admitted to Morristown Medical Center, and they either had an admitting diagnosis of ischemic stroke or TIA, or this data system is pretty unique and it was very beneficial for us because it actually will collect any anything that's electronically entered, so typed in, you can free text any information and you could data pool all of that information. So it doesn't have to be pre-coded. It also collects all freehand information. So what we were able to do, besides the admitting diagnosis, which was pre-coded, we were able to do a problem list, pulling from anywhere that anyone entered anything electronically of, we used CVA, acute stroke, stroke, TIA versus stroke, cerebellar stroke, hemiparesis and lethargy, ischemic stroke, TIA. And this got us a good amount of patients, but we realized when we had started doing this in May that we were still missing some patients. So we went back in and we added an additional criteria of dizziness, giddiness, plus a change in mental status. And this turned out to be a huge help for us, and I'll go into, I think, on the next slide a little bit more about that, but it really got a lot of patients that we were missing in the beginning. That hadn't quite reached that diagnosis of stroke yet. So we excluded everyone age less than 18, length of stay greater than 120 days for data collection, comfort care, contraindication for antithrombotic therapy, or if the patients were discharged, they left against medical advice, they passed away, or they went to hospice. Okay. So what we looked at was pre-implementation data, and we collected it for Q1 from 2014. And then post-implementation data we've been collecting ever since. So I'm going to report on the data from Q3 and Q4 of 2014, as well as Q1 of 2015. So we used the United Healthcare Consortium, or UHC, database to collect NQF 04, 35, 36, and 39, which was basically the medications that the patients were discharged, the antithrombotics, the anticoagulation if they had AFib or aflutter, and the statins if necessary. We used a program called Horizons Medication Manager to collect whether or not the patients were on antithrombotic therapy by the end of hospital day 2. And we also used this same system to check for pharmacist interventions. And finally, we used Horizons Care Manager, was used to collect documentation regarding stroke education because there's an education record that we're supposed to type our education into in that system. Okay, so our results, so what we saw with our antithrombotic therapy by end of hospital day 2, pre-implementation, we're only about 60%, and post-implementation, I didn't report out quarter 2 data because 1, we started in May, so it was in the middle of the quarter, and 2, we did make a couple of changes after that. So that's why I started with quarter 3. But once we ironed out the wrinkles, starting in quarter 3, quarter 4, and quarter 1 of 2015, we're at almost 100% every time. So a big benefit, and what we saw, the reason we think behind this was because the physicians didn't know, or the consults didn't go through that the patient actually had a stroke for at least 24 to 48 hours. So at that point, you already missed that 2-day cutoff by the time the physician was able to see these patients or be notified of the stroke. So by adding that extra criteria of dizziness, giddiness with altered mental status, it did give us more than the stroke patients, so we had to fish through a little bit more of patients to find out if they were really having a stroke. But it gave us the benefit of being able to early identify patients to really get our numbers up for this. So this is the biggest difference we saw, and we believe it's due to that reason. Okay, so looking at discharge, results of medications at discharge. So the orange is anticoagulation therapy. The blue is antithrombotic therapy. And in those 2 categories, even in quarter 1 pre-pharmacist intervention, the physicians in general did a pretty good job at that. There were upwards of 90+% in that category. And pharmacists had few interventions, maybe 10 to 15 per quarter for those. But we did help a little bit, but not significantly. Where we did see a significant change was actually statin therapy, and that was about 70% prior to pharmacist implementation, and we got that well into the high 90s post-pharmacist interventions. Okay, so stroke education. What we found here is the blue line is the nurses, and primarily at our institution, the nurses are the ones who provide detailed and documented education to the patients. And we found that they were hitting about pre-implementation about half of the stroke patients, so about 50%. The red line, and you'll see in quarter 1, is the physicians, and it was a very, very low number, less than 5% usually for the physician stroke education, and I'll talk a little bit more about that in a second. And then the black line is total. Okay, so starting in quarter 3, when the pharmacists were now getting involved, still the nurses are the leaders in providing the education and information, but we would review, and if the patients were not educated, we would go ahead and provide the education. So we did educate between about 30 to 40% of patients. So we were able to supplement and help out the nurses in getting that education to get our numbers up in that area. And the physicians remained consistently low. So that's just something we'll talk about in a second. Okay, so interventions that we made, total in the 3 quarters, there were 551 recorded pharmacist interventions. Sometimes pharmacists make interventions and they don't record it, so that's sort of a lack of a problem. But we had 551 recorded pharmacist interventions in 3 quarters. And as you can see, most of them were regarding this antithrombotic therapy on day 2. There were 308 interventions for that. And the other main area where we saw interventions, again, was the discharge on a statin. Okay. So in conclusion, we believe pharmacists can have a clinically significant impact on meaningful use measures for stroke. Pharmacists had the greatest impact on stroke, 5 NQF0438, the ischemic antithrombotic therapy by day 2. And again, we believe we got that by adding that additional criteria to detect patients before they were even coded as stroke or had consults done. Pharmacists also made numerous interventions regarding stroke 6 NQF0439, ischemic stroke discharge on statins. And then pharmacists played an important role in supplementing education to stroke patients and their family. So other findings that we saw were physicians actually did often educate on stroke. When we spoke with the patients and then even the physicians that were consulted on them and seeing them, they did say that someone did speak to them about their disease state and their medications. But however, the physicians in our hospital were not recording this information where they're supposed to for us to get credit for it in the education record. So even though many physicians did educate, they were not recording it appropriately. Stroke education provided by nurses and physicians, we also found was often incomplete or very inconsistent. So there are 4 key points that, according to these measures, have to be met in order for the education to be considered that you get credit for it. And these include activation of emergency medical system, need for follow-up after discharge, medications prescribed at discharge, and that patients are aware of risk factors for stroke, warning signs, and also symptoms of stroke. So what we did after, kind of getting a little more information is pharmacy, in conjunction with the stroke coordinator, and then it went through the stroke committee at the hospital. We put together a standardized stroke education packet that we now hand out to these patients so that we ensure that they received all the key points so that when we go in and mark our education, we can get full credit for that. I'd just like to acknowledge my counterpart at the hospital, Kunal Shah. He's an internal medicine clinical pharmacist at Morristown Medical Center, and he, along with myself, did most of the counseling on these patients. We also had a patient education pharmacist, and they did some of the counseling as well. That role fluctuated depending on who is in that position, so there are several pharmacists that do that. Also, Laura Riley, she's an RN, and she's our stroke coordinator at Morristown Medical Center. And then Carol Jones is a nurse manager at Morristown Medical Center who worked with us as well. Are there any questions?